530 patients, really critically analyzing ASA, what it means.
It's 100 patients with a BMI over 40.
Is there an actual anesthetic risk? No difference. The complication rate.
Welcome to the latest episode of The Rest is Plastics, the Journal of Plastics, Reconstructive and Aesthetic Surgery podcast. This week I'm on my own, your host, Anton Fries, as James is away, but I'm holding the fort without him. And today I had the absolute pleasure of interviewing Dr. Kathleen Armstrong about her paper, Masculinizing Chest Surgery Outcomes by Body Mass Index and American Society of Anesthesiologists class in Ambulatory Care. Dr. Armstrong is a plastic surgeon and surgeon scientist jointly appointed as Chief of Plastic Surgery at the Women's College Hospital Institute in Toronto, as well as being Assistant Professor in the Department of Surgery in the University of Toronto. It's a great paper and a great episode. Dr. Armstrong, welcome to the podcast. Thank you so much for joining us to discuss your paper, Masculinizing Chest Surgery Outcomes by Body Mass Index and American Society of Anesthesiologists class in Ambulatory Care. It's a great paper in our recent journal, and we're really excited to talk to you about it.
Thank you. Thank you so much for having me.
It's our pleasure. You're obviously a very high volume practitioner and expert in this field, but what inspired you to investigate this specific topic?
When I started doing top surgery 6 years ago, I started in a private community clinic. And then in that clinic, we were simply doing people who were under BMI 35 and also relatively healthy because it's an outpatient facility. And then I was hired on by the university in order to work at Women's College, where we're still an ambulatory facility. So we don't typically keep people overnight. We don't have a blood lab on site. We have like 2 units of blood available at any given time, and we don't have ICU. So a little bit more ambulatory than a lot of the hospitals that people live at. But in Toronto, at the same time that I was starting at that hospital, there was no other place that was really offering gender-affirming top surgeries within the city that was a higher acuity facility. And so we had to figure out slowly how to expand access for patients in a safe and comprehensive way.
Great. So essentially you had these two locations, and I guess the perceived to be higher risk cases couldn't be done in these facilities.
Yes, exactly. We were starting out when I came on in 2020 or 2021. It was the expectation at both facilities that we were going to keep to lower BMI patients, lower ASA, because they're both outpatient ambulatory facilities. But the anesthesia team that we coordinated with at Women's College, they're amazing, and they were willing to start slowly pushing the border up to see what we could do safely, what was the real evidence that was dictating a BMI cutoff of 35 or a BMI cutoff of 40, like really critically analyzing ASA and what it means. If someone has, for instance, POTS and Ehlers-Danlos syndrome, what does that really mean for their true anesthetic risk? Is there an actual anesthetic risk, even though they classify personally as being higher?
Would you mind describing the methodology of the paper for us?
Yeah, so it's a retrospective chart review of all patients that we had seen at Women's College Hospital, so only my hospital location. So there's 530 patients included, and the age range of the patient was from 15 to 66 years old. And it was all masculinizing top surgeries. So the top surgeries we included were periareolar keyhole surgeries, double incision, which is the standard with and without echografts, inverted T mastectomies, and then breast reductions, like people who were seeking breast reductions for gender-affirming reasons. And then we looked at the BMI range, and so the BMI range for those patients was 16 to 58.7. And then the ASA range was from ASA 1, and then there were ASA 3. I think it was 3 and then maybe 4, but that was collapsed into 1. Yeah. And so we, of the studies that have been done, had a really good demographical representation of higher BMI patients, like true above 40, above 45, above 50, and also of high ASA classifications. And then what we did was we looked at the types of complications. And so we classified them by the severity of the complication. And we found that there was no difference in the complication rate based on BMI or on ASA classification of the patient.
Yeah, it's kind of striking in your results that I think you had over 100 or almost 100 patients with a BMI over 40, which seemed extraordinary.
Yeah, it's a good volume representation to show that the numbers are real.
Yeah, it's very, very impressive, and obviously, really beefs up your, your ability to make conclusions. So what were the results then of the paper?
Yeah, so if we looked at the BMI, we found that there was no difference in complication rate based on the obesity classification system that we used. So we used underweight, normal weight as the first classification. Then we used overweight. Then we used classification obesity 1, obesity class 2, and then obesity class 3. And then we compared across those groups based on a scoring system in order to grade the severity of the complication. And we found even using that grading to collapse some of our complications. So like hematoma, seroma, drained at the bedside is whatever classification, and hematoma evacuation in the main OR is another classification that's of higher severity. And I think the most important thing was that there were very, very few high complications or high severity complications.
Absolutely. I mean, you've sort of shown the safety of this, and that's obviously a good scale, and so the complications are graded, aren't they, from sort of non-operative to kind of office-based minor procedures, and then obviously operative procedures, and you showed there was no difference based on either BMI or ASA, and that included, as you say, 100 patients or 98 patients with a BMI over 40. So, you mentioned, you listed several techniques that you use, and this is not my area of expertise, and but some of the names sound familiar. But can you, do you modify your techniques to achieve this safety, or, for example, if there is a bigger patient, or are they kind of anatomically based techniques, and this is a more of a systems approach? Would you explain to someone who would be more concerned about these BMIs that this is safe?
Yeah, I think that you have different approaches for different BMIs. More of it is based on breast size, but then breast size often travels with BMI. So you are finding that people that are of higher BMI are qualifying not for a keyhole or a periareolar, which doesn't get rid of any extra skin, because the assumption is there is very little extra skin at those people, like an A cup breast or smaller. And so typically people who are of higher BMI are going for either a double incision with or without the nipple grafts. They can also commonly do the inverted T mastectomies. So that's a pedicle. Usually I use a superior medial, or always I use a superior medial pedicle in order to rotate the nipple areolar complex up higher to the masculine position, or they're choosing a gender-affirming breast reduction.
I read in the paper that you had a small rate of seromas, but you don't use any drains.
Yeah.
And I like the explanation in the paper, but perhaps for the listeners.
I'm very opposed of drains, because I think sometimes you use the drains and then you still get a seroma. You pull it out, you still have a seroma, or you're in the situation where you have a drain in for 2 weeks and you're like waiting to pull this bad boy out. So I learned with a surgeon on lower BMI people to always use a drainless technique. And so when I started progressively increasing the patients that I was operating on with regards to BMI, I just kept with the drainless technique for the double incision, the inverted T, and the breast reductions. And I find that I do get some seromas, but my mindset is that I want my patients moving. I want them having low pain scores. I don't want them to be like freaked out by the drain that they're having to carry around with them. So I think it helps with recovery. And then if I do have to drain a seroma, I can drain it just through the scar site. So it's a painless technique, and it can always be done in the office. People tolerate it so well. And so I really believe in this enhanced recovery after surgery kind of time. Like, I believe in all of it. I give blocks. I give pre-op Tylenol. So everything I'm doing or strategizing within my surgical approach is to get people on an recovery after surgery trajectory.
Great. And when you say a no drain technique, do you do some internal
Yeah,
sutures?
progressive sutures. Yeah. And I
Fantastic.
also think that's great if you get a hematoma because you can imagine on someone with a BMI of 45, 50, there could be a lot of potential space. But if you kill that space with a whole bunch of progressive tension sutures, then your chance of getting a massive hematoma really decreases. And so that's way better than putting a drain in because the drain won't prevent that.
Yeah, I mean, the BMI 58 top surgery, the mind boggles, but fantastic. So, I mean, I guess, you in your introduction, you sort of said that this paper was all about changing practice and broadening access. So how has that come to pass?
Yeah, I think we've received a lot of positive feedback in Ontario. People, feel optimistic that they can access surgery. There's no, stringent guidelines. It used to be very anxiety provoking for people to think, oh, I have to lose 10 pounds, I have to lose 20 pounds, I have to lose 100 pounds, sometimes before I can access surgery. And we also see another paper that we had done was about healthy habits after top surgery. So sometimes it's not until people access top surgery that they really feel like they're motivated to go to the gym or they're motivated to go do these things to take care of their body. So I do think it sometimes has to come first before people can make those other positive changes for themselves. And I think it's a hugely important surgery for people to be accessing. I worked with the Gender Q group, I was part of that study. And if we look at all the Gender Q data, the thing that outperforms everything is top surgery. Like the scores are like 10 out of 10 across the board, regardless of what you do. People are so happy. It's almost like people are so happy, it makes it hard to differentiate from anything because it's a blanket happiness that occurs with top surgery access, which is, I mean, it's great to be a provider.
Your 500 patients every year, a couple of years. You must be the most popular doctor in North America.
For top surgery
Top-
in
well,
Ontario. Don't know why, not
sounds
why.
that's fantastic. Are you going to be able to do these? You think the higher risk patients in the surgical center environment versus the hospital, based on this?
Yeah, so we're shifting what we're doing in the surgical center too, based on this. So when I started with Dr. McLean, he was my predecessor. We were at BMI 32, and then we moved to 35, and then now we're at 40, basically. And so we're kind of pushing it there. But I think having the data first, and then backing it up that way is really important to sort of shift mindsets about these things, because for a lot of times, when I was starting out, people said, oh, we only operate on people under 35 for breast reductions, for top surgery, for a whole bunch of things. And then I always thought it was anesthetic risk because, a wound dehiscence, who cares? It's like a week, 2 weeks of dressing changes for a life-altering procedure. People aren't going to turn away from a procedure because of a wound complication that resolves within a month. So I thought it must be the anesthesia risk. And then I talked to my anesthesia colleagues and they're like, no, it's, we think this is safe to do together. Let's start doing this together. So it's been like an amazing team opportunity. And now we applied recently with my anesthesia colleagues as well for a CAHR grant to look at what are the systems in place that are sort of enforcing these BMI restrictions within the hospital system more broadly. Where do they come from? And like how, are they valid?
Yeah, it's fascinating, isn't it? And even saying they've got wound complications, I mean, your data kind of suggests they don't have wound complications.
Yeah, it's
So
true.
moving from the BMI to the ASA, how do you see that side of it? It seems like, again, looking at your numbers, you've got a roughly even split between class 2 and class 3, and then a smaller number of class 1s. What sort of problems are that these patients have?
Yeah, I think the trans community in general has some comorbidities that exist. So BMI is a big one, as it is for a lot of other general patient populations. So that would automatically bump up their ASA classification.
Mm.
And then I think there's other things, like sometimes it's smoking. Sometimes, I mean, I've operated on there's a lot of diabetes I see, as you would see elsewhere. And then within the trans community, we see a lot of either Stanlos, POTS, fibromyalgia, like complex mental health, that might require like multi-pharmaceutical sort of situation that would bump up ASA classification. So I think it's just really being thoughtful and dissecting what does this actually mean? Like, what does hypermobile EDS actually mean for the anesthetic risk, for the surgical risk? Does it warrant us not offering surgery to this person?
It's a great paper, and it's like all the best research is having real world effects and benefiting patients. So, congratulations again. Moving on, we commented already. You're a very high volume practitioner in this area, but what led you to this field?
I always say it was serendipity. It was like right time, right place. I graduated in 2019 from University of Toronto, which is where I work right now. When I graduated, there wasn't a lot of people within the residency program offering gender-affirming top surgery. We were just developing a program at Women's College. But I had done like enhanced recovery after surgery. I did a master's during my residency program, health economics. And so I knew I wanted to be an academic, and I knew I wanted to do research, and I knew I wanted to work with a patient population that I was passionate about. And so I had the opportunity at Women's College Hospital to learn more about gender-affirming surgeries, because there was a job posting that was going to be coming up in that field. And so I went to Mississauga, which is really the next neighborhood over, or next city over. And I was working for a while with a high volume provider at the time. He'd been offering surgery since 1999 and was doing the biggest volumes in Ontario before I came in. And so he trained me in surgery, and I just instantaneously, it was a perfect fit for me. It's a super cool patient population, really rewarding surgeries, a huge deficit in research where you can make a big difference.
Yeah, congratulations. It's great when all that sort of comes together. It's an inspirational story. Finally, we're having a Women in Plastic Surgery special edition of the journal coming out soon. There'll be a podcast to accompany it, pleased to say. How would you sort of summarize that sort of field at the moment, perhaps where we've come from and what challenges remain?
Yeah, I mean, I feel really proud, happy to be a woman in plastic surgery right now. I think it's very different than it was 10 years, 20 years, 30 years ago. I would say that U of T, University of Toronto, out of all the programs, is probably really proactively recruiting female surgeons for all levels too. So right now I'm the head of plastic surgery at Women's College Hospital. There's a ton of females within our division, like at the University of Toronto. I'd say it's pretty much 50-50, as well as our residency program is pretty much 50-50. So I think there's always things that we could do better for everyone, like not just women, like parental leave could be better. That could be even sabbatical leave or sick leave and stuff like that. I think the larger problem is like burnout in healthcare in general, and how do we support everyone? And I think also like supporting men is important to take a pat leave, because then it's not always the woman's responsibility to take the maternity leave or whatever, the parental leave. So I think if everybody has those benefits of like a good work-life balance, that it just makes your job so much more enjoyable, and it gives you the motivation to take care of people the way that they deserve to be taken care of.
Yeah, sometimes that can makes you a better doctor.
Yeah.
Even by having that perspective and that balance, which perhaps traditionally we haven't necessarily honored in our profession.
Yeah, and I feel super lucky. I had 2 kids in my residency program, and so I did my master's. I came back. I did 1 year, my 3rd to 4th year. Then I went off for a year-long mat leave, and when I was asking for a year-long mat leave, I was super nervous. I was the first one gonna ask for that. And so I thought maybe they would say, oh, no, I don't think that's a good decision for you. You're not that strong of a surgeon. Maybe you shouldn't be off that long. But they were like, yeah, do it. Go do it. Or come back. And I always felt very well supported from the program through that decision making. And then my second child I had when I was writing my college exam and then just graduating. So I graduated June 23rd, and I had my son June 25th of the same year. Yeah, so it was really perfect timing. Yeah. But I took 6 months, 7 months off with him, and they really supported me with that decision making too. And then another thing, people always say you got to go away for fellowships, you got to do this, you got to do this. And my husband and I, we own a brewery in Toronto, which is off topic, but his brewery is not mobile. Like, he couldn't go on fellowship somewhere else with me. And the university was like, we don't care. Like, we want you. We see what you bring, and you can get that additional, more international perspective through other methods, like other modalities than a formal fellowship training. So having that flexibility to accommodate people that are really motivated to participate. Like, right before we got on this conversation, I was doing a lecture for a medical student and a resident, so I've seen how the university has invested in me, and so I want to invest back in it. I think that's what we need.
Phenomenal. So living proof that this all works.
Yeah, sure.
And we'll have a separate podcast about the brewery on site.
We did that during my master's.
Okay, really?
That was a master's side project, but now it's like 12 years deep. So
phenomenal. We'll do it on site. We'll do the rest is plastics on site. It's going to be great.
I love it.
Amazing. Dr. Armstrong, thank you so much for your time speaking to us today. It's been a real pleasure. It's been a great paper and a great discussion. Our listeners are going to enjoy it. Thank you. Thank you for listening to that podcast. I hope you enjoyed listening to it as much as I enjoyed recording it. Leave us a review, subscribe, like, and consider submitting your research to the Journal of Plastics, Reconstructive and Aesthetic Surgery.